This is a 7.5 minute review of Presby's stroke alert process for emergency medicine nurses and techs. There's separate reviews for our physicians and for our neurology colleagues. It's not a comprehensive review, but the goal of this module is to review our stroke alert process, including the imaging we are doing, and emphasize our individual roles and priorities in the algorithm, highlighting areas where we can improve our efficiency. A stroke alert can be activated for any patient who presents to our emergency department with acute stroke-like symptoms within 24 hours of last known well. These include, but are not limited to, sudden numbness or weakness of the face or extremities, especially on one side, sudden confusion, trouble speaking or understanding, sudden trouble seeing in one or both eyes, sudden trouble walking, dizziness, loss of balance or coordination, sudden severe headache with no known cause, and even consider in patients with sudden onset altered mental status or new onset seizure. By initiating a stroke alert, we're activating a coordinated team effort by emergency medicine, neurology, and radiology to work in parallel towards the goal of rapid identification and treatment of patients with intracranial hemorrhage, select patients with ischemic stroke who are eligible to be treated within 4.5 hours of last known well with TPA, and select patients who present to our emergency department up to 24 hours from last known well with ischemic stroke due to a large vessel occlusion and are eligible for transfer to HUP for mechanical thrombectomy. In January of 2018, the DAWN and DIFFUSE 3 trials were published supporting this expansion of mechanical thrombectomy to select patients up to 24 hours from last known well. Although these trials did not change treatment with TPA, in our effort to simultaneously identify more thrombectomy candidates, we modified our process, and patients are spending much more of their initial evaluation in CT. As our stroke alert process has evolved and become more complicated, our goal to initiate TPA and our decision to transfer is still less than 45 minutes, stressing the importance of efficient teamwork. So to review, if you identify a patient showing signs or symptoms concerning for stroke, ask for an immediate stroke evaluation. Once a stroke alert has been activated, an ED room should be assigned so the receiving ED nurse and attending are assigned. While the patient is being mini-regged, update the patient's blood glucose, vital signs, and weight. These should occur where the patient arrives, either at triage or in the landing zone on the dedicated stroke stretcher. Ordering TPA is dependent on the patient's weight, so make sure you enter the weight immediately after it's obtained and communicate this with the EM physician. As long as the patient is hemodynamically stable and is protecting their airway, they'll go directly to CT. You should go to CT with the patient with the stroke transport monitor. The patient needs Q15-minute neurochecks and vital signs until reperfusion decision. In the CT scanner, both the emergency medicine and neurology physicians should be assessing the patient for stroke or alternative diagnoses. At the same time, you're drawing blood and obtaining an 18-gauge IV in the right AC for upcoming vascular imaging. After the completion of the non-con CT head, there should be a discussion to determine if the patient is TPA eligible, and if so, the EM physician should order TPA then. At this time, it should also be determined if the CTA of the head and neck and CT perfusion, which are ordered as part of the stroke alert order set, should be completed. CTAs are used to identify patients with large vessel occlusion, specifically the internal carotid, proximal middle cerebral, and basilar arteries, vessels that neurointerventional may intervene on. CTAs will also identify dissections and areas of stenosis. The NIH stroke scale is probably the best predictor of large vessel occlusions, but we know even if we use a low threshold, we will miss some. For example, using an NIH stroke scale of greater than or equal to 6 in patients with ischemic stroke, we'll miss approximately 1 of 8 large vessel occlusions. So if it's thought the patient is having a stroke, unless they have a contraindication to IV contrast or the study is delaying administration of TPA, then they should have a CTA. So what are CT perfusions for? CT perfusion provides important information about the hemodynamics of the brain parenchyma. In this example, the area in green on the 16 slices to the right is highlighting the area with prolonged mean transit time, or slow or delayed perfusion. The area in purple on the 16 slices to the left is highlighting the area with significantly decreased cerebral blood flow, representing the area of the brain which is already infarcted or is destined to infarct. If there's a mismatch, a larger area of the brain with decreased perfusion but maintaining its cerebral blood flow, this represents the penumbra, or an area of brain at risk for infarcting but at this point is salvageable. In this example, this patient has a large area of mismatch and would benefit from thrombectomy. So if the patient is having a stroke, The non-con CT is used to rule out intracranial hemorrhage. CTA is used to identify patients with large vessel occlusion, and CT perfusion can help identify which of those patients with large vessel occlusion would benefit from transfer to HUP for mechanical thrombectomy. Once imaging is complete, the patient will be transferred to their room in the emergency department. If the patient has a head bleed, our initial treatment should be to elevate the head of the bed and focus on blood pressure control and reversal of any coagulopathies. If the patient is going to receive TPA, they'll need a second IV, and you'll need to complete the TPA flow sheet, documenting vital signs and neurochecks every 15 minutes. Blood pressure needs to be less than 185/110 to receive TPA, and the EM attending must be in the room for the TPA bolus. If the patient has a large vessel occlusion and is being transferred to HUP for thrombectomy, the transfer should be arranged via PEMSTAR. And if the patient has an ischemic stroke but is not a TPA or thrombectomy candidate, their blood pressure should be treated only if above 220/120. Make sure to complete and chart the aspiration risk tool before giving or documenting any PO medications. In summary, the Stroke Alert activates a coordinated team effort to rapidly identify patients with intracranial hemorrhage or ischemic stroke that could benefit from treatment with TPA and/or transfer for mechanical thrombectomy. And our goal is to complete all of this in less than 45 minutes from patient arrival. So finally, 3 minor but important areas I want to highlight to ensure an efficient process. Make sure to obtain the patient's weight where they arrive. The TPA order is dependent on the patient's weight, so make sure you enter the weight immediately after it's obtained and communicate this with the EM physician. In the CT scanner, when you obtain an IV for vascular imaging, make sure someone sends the drawn blood immediately to the lab. And if the patient is not receiving TPA or being transferred, make sure to complete the aspiration risk tool and chart its completion before providing or charting any PO medications. Overall, we're doing a great job, but we're always striving for improvement. Our Stroke Alert algorithm is posted in the ED and on our website for a review. Please reach out to me with any questions or suggestions. Thank you.